There have been a number of randomized trials in chronic atherosclerosis that have looked at subsets of patients for peripheral artery disease, particularly for the risk of major adverse cardiovascular events. More recently, also major adverse limb events like acute limb ischemia. What there's little known about is the risk profile and best therapy for patients in their most vulnerable phase, which is after lower extremity revascularization. We know from large data sets of patients of 400,000 patients or more that the risk profile for major adverse limb events is extremely high in the first 1 to 2 years after revascularization, regardless if it's for critical limb ischemia or for claudication. And there have been few trials in this setting. In the past, there was the Casper trial for dual antiplatelet therapy versus aspirin alone, which showed no efficacy for that. And then a trial called the Dutch BOA trial looking at warfarin, which again was not efficacious for graft thrombosis. So VOYAGER-PAD sought to examine this population in this setting, had a unique primary endpoint composite of irreversible harm events of the heart, limb, and brain, a 5-point composite endpoint. And it tested a regimen of aspirin plus rivaroxaban, 2.5 milligrams twice daily, versus aspirin alone, a regimen shown to be efficacious in the chronic COMPASS trial. And it was initiated in a pragmatic way post-revascularization. Overall, the trial demonstrated that this combination was efficacious and reduced the primary endpoint by 15%, but more notably, an absolute risk reduction of about 2.6%, or number needed to treat of 39. There was more bleeding, but no excess in intracranial hemorrhage or fatal bleeding. VOYAGER-PAD was designed to be pragmatic and inclusive, so patients could be in the trial if they had an endovascular revascularization or a surgical one, whether they came in with claudication or CLI, whether it was their second or third revascularization or their first one. And so it was a broad population. It also included the ability of the investigators to use clopidogrel at their discretion. And because it was a broad population by design, there are a lot of questions about the efficacy and safety in key subgroups and findings for specific endpoints. Over the course of 2020, there have been a series of presentations, 5 of which were at the American Heart Association meeting. These have looked at various subgroups. So for example, patients with polyvascular disease who had concomitant coronary artery disease had a very large benefit for major adverse cardiovascular events, with a 22% reduction looked very similar to the Voyager trial. In contrast, those without coronary disease had a lower risk of MACE, but still a very high limb risk and derived benefit on the basis of a reduction in acute limb ischemia. We also saw in subsequent presentations that patients who were coming up for their second or third revascularization, so those with a prior history, had an even greater benefit overall for the primary endpoint, when there was actually statistical heterogeneity. So that's a high-risk group that derived a great benefit. We also see that for another population with severe limb disease, those requiring surgery, and that was presented at the ESVS. Other subgroups of note include those with renal dysfunction, again, a high-risk subgroup where the efficacy and safety of rivaroxaban were consistent, but because of the high-risk profile, a greater absolute benefit. And then several subgroups which bear mentioning at the American Heart Association meetings. The first one is the critical limb ischemia subgroup. This was over 1,500 patients, a very large CLI subgroup, more than all of the mega trials and chronic PAD combined. And in that subgroup, the incidence of the primary endpoint was very high. About 1 in 4 had at least one event of irreversible harm event of the heart, limb, or brain. And there was a large absolute risk reduction with rivaroxaban, consistent with or without CLI, but a greater absolute benefit in those with CLI. And the safety appeared similar to those, regardless of whether or not you had CLI. And we looked at net outcomes, including all-cause mortality, an important measure in CLI patients because of their high competing risks. When you looked at the primary endpoint with all-cause mortality, intracranial hemorrhage, or fatal bleeding, and net outcome, there was a significant reduction with rivaroxaban that was statistically significant. So I think promising data for them, as well as promising data for the endovascular subgroup, which showed that there was a benefit, particularly for limb outcomes, and that most of those patients received clopidogrel, and so that the benefit was on top clopidogrel or regardless of clopidogrel. A couple of other analyses included the risk of venous thromboembolism, which was significantly reduced, and a health economics analysis, which showed that the use of this strategy after peripheral revascularization reduced the costs by over $2,000 per patient. I think overall, when we look at Voyager and what we've learned from the sub-analyses so far, we see that patients with peripheral artery disease undergoing revascularization are very high risk, regardless of aspirin, statin, and even clopidogrel use, with an event rate of about 19 to 20% at 3 years in spite of best medical therapy. That's a very high risk cohort. And that rivaroxaban reduces this risk at the cost of bleeding, but without intracranial hemorrhage or fatal bleeding. What we've seen in all the subgroups is that the relative effects in terms of efficacy and safety appear consistent so far in all the major subgroups, but there are patients that are higher risk that we might worry about more in the clinic. And we've learned that the polyvascular patient with coronary disease is at a very high risk of MACE. And we've learned that there are patients, even if they don't have coronary disease, that are very high risk of limb outcomes. And those are the patients with multiple prior revascularizations, the patients who require surgery with long lesions, and those patients with critical limb ischemia. Those are just some of the patient profiles that we've seen in these sub-analyses where there's really an extreme risk profile and an even greater absolute benefit of therapy. So that's a take home for 2020.